Stand up for a moment and walk across the room. Just 5 or 6 steps, the way you normally do. Now sit back down. I want you to know that in those 5 or 6 steps, if you are over 50, there is a very good chance you committed 3 or 4 of the 7 mistakes I am about to describe. None of them feel like mistakes when you are doing them. They feel like walking. That is exactly why they are dangerous. After 30 years of clinical observation, I have seen these 7 walking errors destroy more knees than any sport, any injury, and any genetic predisposition combined. The good news is that every single one of them is fixable, and most of them are fixable in less than 2 weeks of paying attention. Quick note before we go further. This is educational content, not medical advice. The corrections I am about to describe are general education. They do not replace evaluation by your own physical therapist or physician. If you have had recent surgery, severe osteoporosis, or significant balance impairment, please work with a hands-on clinician before changing the way you walk. Dr. James Whitaker is a composite educational character built from 30 years of represented physical therapy experience. With that on the table, let me show you the 7 mistakes. Mistake number 1 is the heel strike slam. Most adults over 50 land on the back of the heel with the knee fully straight and the foot ahead of the body. When the heel hits and the knee is locked, the force of your entire body weight travels straight up through the heel bone, through the shin, into the knee joint, and into the hip. There is nothing to absorb it. The knee is the absorber, but a knee that is fully straight at the moment of impact cannot absorb. It can only transmit. A 2019 study in the Journal of Biomechanics, following 280 older adults, found that participants with the heaviest heel strike had 3.5 times the rate of knee pain progression over 5 years, compared to participants who landed with a slight knee bend. 3.5 times. From one variable, the heel slam. The fix is small. You do not need to learn to land on the forefoot like a runner. You just need to allow the knee to be slightly bent, maybe 10 degrees, at the moment the heel makes contact. The way this is taught in clinical practice is to ask the patient to imagine they are walking on a wood floor and they are trying not to wake somebody up in the next room. Quiet feet. When you try to walk quietly, the knee unlocks automatically. The body knows how. It just needs the instruction. Mistake number 2 is what we call hip drop, and the formal name is Trendelenburg gait. When you stand on one leg, the muscle on the outside of the supporting hip, called the gluteus medius, is meant to hold the pelvis level. If the gluteus medius is weak, the opposite hip drops down with every single step. The patient never sees it. The family member behind them sees it. The knee absorbs the drop. Step after step after step, 10,000 times a day, that small drop torques the knee inward and stresses the inner ligament. Case after case I have seen documented for inner knee pain turned out to have a sleeping gluteus medius, not a knee problem. The knee was the messenger. The hip was the culprit. Test yourself. Stand sideways to a mirror, lift one foot a couple of inches off the floor, and watch your pelvis. If the hip on the lifted side drops below the hip on the standing side, your gluteus medius needs work. The simplest fix is a sideways step against light resistance. Loop a small band around your ankles. Bend your knees a few degrees and step sideways 10 paces in one direction, 10 back. Twice a day, 3 weeks. The muscle wakes up. The drop disappears. The knee pain often follows the drop out of the picture. Mistake number 3 is the locked knee swing. This is the cousin of the heel slam. As your leg swings forward to take the next step, some adults keep the knee dead straight all the way through the swing. The leg becomes a stiff pendulum. By the time the foot lands, the knee has had no opportunity to soften. The hip flexors are doing all the work, and the lower back is compensating. The fix is to let the knee bend slightly during the swing, just enough that the foot clears the floor without dragging. Watch a small child walk. Their knees swing freely. The locked knee swing is something we acquire in middle age, often from years of cautious walking, and it can be unlearned. Mistake number 4 is overstriding. The patient takes a longer step than their hip can comfortably produce, and the foot lands well in front of the body's center of mass. Every overstride is a small braking force. You are pushing yourself forward and then catching yourself with a long leg, which means the ground is pushing back at you through the knee. A 2020 paper in Gait and Posture, looking at 360 older adults, found that step length above the natural range was associated with a 40% higher incidence of knee pain at 12-month follow-up. 40%, from taking steps that are too long. The fix here is counterintuitive. Take shorter steps and walk slightly faster. The same overall pace, distributed across more contacts with the ground. Each contact lands closer to the body. The braking force drops. The knee thanks you. Most patients in the cases I have reviewed looked at the clinician as if I had asked them to walk backwards. Within a week of practice, they reported walking felt easier and the knee felt quieter. Mistake number 5 is foot out, toe out. Some people walk with their toes pointed outward at an angle, like a duck. Some of that is structural and cannot be changed. But a lot of it is habit, often acquired after a knee or hip injury years earlier. When the toes point out, the knee tracks outward over the foot, and the inner knee ligament takes load it was not built to take. The kneecap also tracks poorly in its groove, which is the recipe for what most patients describe as front of knee pain. Let me pause here for a moment because this fix surprises people. You do not need to force your feet straight. That overcorrects and creates its own problem. You simply imagine that your second toe is pointing forward, not the big toe, the second toe. That brings the foot into a neutral position without forcing it. Walk a hallway, second toe forward. Notice how the kneecap feels. Most patients tell me the knee feels lighter within one short walk. Mistake number 6 is the looking down posture. Adults over 60 develop a habit of watching the floor as they walk, especially if they have had a near fall or live in a home with thresholds and area rugs. The chin drops, the upper back rounds, the center of mass shifts forward, and the knee has to absorb a body that is leaning into every step. Case after case I have seen documented for chronic knee pain showed a posture that looked like they were carrying an invisible weight on the front of their chest. The knee was working twice as hard for the same step because the body was no longer stacked over it. The fix is one word: horizon. When you walk, you look at the horizon, not the floor, not your phone. The horizon, or the far end of the hallway if you are indoors. The chin lifts, the upper back lengthens, the chest opens, the center of mass moves back over the foot. The knee gets a break it has not had in years. If you are worried about floor hazards, scan the floor every 5 or 6 steps, then return your eyes to the horizon. Do not live with your eyes on the ground. Talk to your physical therapist or physician if you find that looking up makes you feel unsteady, because chronic looking down can also weaken the small muscles around the neck and inner ear that contribute to balance, and that is a separate piece of the puzzle. Before I get to number 7, a brief word on why we have these mistakes at all. Almost none of them are weakness in the simple sense. They are protective patterns. After a small injury, after a fall, after a season of pain, the body learns to lock the knee, point the toe out, or watch the floor as a way of avoiding the thing that hurt. The pattern stays long after the original injury has healed. The brain forgot to switch it off. When we change the way you walk, what we are really doing is reminding the brain that the protection is no longer needed. The muscles will follow if you give them a few weeks to listen. That is also why progress on these corrections is not linear. You will have a brilliant week where the new pattern feels natural, and then a tired week where the old pattern returns. That is normal. The old pattern was practiced for years. The new one needs months. Most patients in the cases I have reviewed saw the corrected pattern lock in around the 8 to 12 week mark, not in the first fortnight. Mistake number 7 is the slow shuffle. Some adults walk so slowly and so cautiously that the knee never extends fully and the foot never properly clears the floor. They are not walking, they are shuffling. Counterintuitively, shuffling is more dangerous than walking at a normal pace. The shuffle keeps the feet close to the floor, which raises the trip risk on any small change in surface, and it deprives the muscles of the load they need to stay strong. The shuffle is often the visible early sign of declining leg strength, and it accelerates the decline by removing the very movement that would slow it. There is research that ought to be on a poster in every senior center in the country. A 2011 paper in the Journal of the American Medical Association by Studensky and colleagues pooled data from over 34,000 older adults and found that gait speed predicted survival as accurately as age, sex, body mass index, and chronic conditions combined. One variable, walking pace, told the researchers as much as 5 other variables together. The shuffle is not just uncomfortable, it is a leading indicator of decline. And it is reversible, in most people, with consistent practice. The fix is to walk at the pace you would walk if you were going to be late for a friendly appointment. Not racing, not strolling, purposeful. A 2018 review in the Journal of the American Geriatric Society, looking at over 15,000 seniors, found that walking pace was one of the strongest single predictors of independence over a 5-year window. Faster walkers stayed independent longer. That is not coincidence. The pace builds the strength that protects the joints that keep you on your own feet. Let me pause again. I have given you 7 mistakes. I do not want you to try to fix all 7 tomorrow. Pick one, the one that landed hardest when I described it. That is probably the one your body recognized. Work on that one for 2 weeks before adding the next. Most patients try to change everything in 1 week and end up changing nothing. Pick one and let the change settle in. 2 composite cases worth describing. The first is documented as Eleanor, 73, a retired nurse. Eleanor had been told her knee was bone on bone and that a replacement was the only option. When her gait was documented, the gluteus medius was sleeping on both sides and the hip drop was visible from across the room. 3 months of sideways stepping with a band and the inner knee pain dropped from a 7 out of 10 to a 1. The orthopedic surgeon she had been referred to agreed she did not need the operation that year. 4 years on, she still does not. The second case is documented as Raymond, 66, who had been a long-haul truck driver for 38 years. Raymond walked with his toes pointed out at almost 40 degrees on both sides. He had no idea. The documented protocol used the second toe forward cue for 6 weeks, alongside some hip mobility work. The front of knee pain that had been with him for 15 years was gone in 9 weeks. Not improved, gone. Case after case I have seen documented heard the same words from a first doctor, and case after case the patient walked out of clinical care moving better than they had in a decade, just by changing how they walked. Before we close, the legal piece. I am not telling you to ignore your doctor. I am not telling you that walking corrections replace medical evaluation. I am telling you that walking is the single most repeated movement of your day, and a small correction repeated 10,000 times has a bigger effect than almost anything else you can do. Bring this list to your physical therapist or physician at your next visit. Ask them which 1 or 2 of these patterns they see in your gait. Ask them to watch you walk for 1 minute and tell you what they see. That single minute of observation in their clinical hands may change your entire trajectory. If you do nothing else from this video, do the second toe forward cue tomorrow. Walk 1 hallway, just 1, and feel what happens at the kneecap. Tell me in the comments which mistake you recognized in yourself. I read every single comment, and the patterns I learn from your replies inform what I teach in the next video. One last thing before I let you go. If you have a partner, a son, a daughter, or a friend at home, ask them to do something for you this week. Ask them to film 10 seconds of you walking down a hallway from behind and 10 seconds from the side. Then sit down together and watch the clip. You will see things you cannot feel. The hip drop is invisible from the inside. The locked knee swing is invisible from the inside. The looking down posture is invisible from the inside. From the outside, on a phone screen, all 3 jump out within seconds. That 10-second clip is the single most useful diagnostic tool you can use this week, and it costs nothing. Take care of your knees. Take care of the people who love you. Until next time, move well, stay strong, pick one mistake, fix it, and come back so we can fix the next one together.